Okay, we'll get started. I think we still have some people coming in. We're admitting. I just want to welcome everyone. Hello, my name is Dr. Anita Palapu. I'm the head of the Department of Medicine and also one of the co-leads for the Data Science and Health Research Cluster. I first like to acknowledge that I'm calling in from the ancestral, traditional, and unceded territories of the Coast Salish peoples, Squamish, Musqueam, and Tsleil-Waututh nations, and I'm very grateful for their stewardship of the lands and also very much committed to the truth and reconciliation calls to action. Really grateful that you're all joining our ethics seminar series that we're launching today. And our cluster is funded by the UBC GCRC competition, and we aim to bridge the gap between health system data and UBC's data science and research infrastructure, hoping to embed analytics and innovation with clinical medicine so that we can ultimately improve the health outcomes of British Columbians. So one of our major foci for the next 2 years is to explore the ethical implications and points of consideration for implementing AI augmented clinical decision support tools. So through our AI Meets Ethics seminar series, we hope to gain some insight into some of the most cutting edge works that are being done in the field and encourage thoughtful conversations about bringing big data and AI into our healthcare system. So before we get into the presentation, we'd like to remind the audience that there will be a Q&A session at the end. So please feel free to put in your questions in the chat throughout the sessions. So with that, I'm very excited to introduce our first speaker, Dr. Charlene Ronquillo, who is a Filipina scholar, a registered nurse, health informatician, and the lead of the Health Informatics Equity Lab at the UBCO School of Nursing. So the goal of her work is to improve the equity in BC's healthcare with thoughtful, inclusive technologies. Her ongoing research aims to ensure the meaningful inclusion of non-dominant groups in the conceptualization, design, development, and implementation of health technologies throughout the health system. Her expertise lies in mixed methods, participatory and co-production approaches, software design and development methods, and technology lifestyle, from conceptualization to evaluation and refinement. So the whole landscape, it sounds like she'll be able to cover. And she is our first cluster EDI co-lead and will be helping us to better incorporate EDI principles into our vision and also into our specific projects as we move forward. So with that, I welcome Charlene to begin the presentation, and thank you so much.
Thank you so much, Dr. Palapu. And thank you everyone for taking the time to join us today. Today, I will be talking about health data foundations and equitable AI. And my intention is really to bring things back to the humans at the end of the day. So the patients kind of at the pointy end of the technologies that we're all researching and exploring and working on. Thank you for the land acknowledgement. I'd like to just add that I'm joining you today from the unceded, occupied, and traditional territories of the Silks Okanagan in the land we know as Kelowna. I'm actually in Vernon today. And acknowledging the privilege that we have gained, the privilege that we all have to be here today, and the privilege that we have gained from the histories and structures of colonization on these lands and the institutions that have built upon them. And you'll see a focus on kind of in infrastructures, legacy systems, histories as shaping how data has been created and continues to be created in our health systems. And I'll speak a little bit about that later on. And my commitment to you today in hopes of moving beyond the land acknowledgement is hoping that we can better ourselves by the ways that we live and work towards truth and reconciliation, towards democratizing knowledge, and highlighting that, especially in the field of health, the importance of interdisciplinary work, that all of our expertise and perspectives are needed to really move towards meaningful and useful AI technologies in healthcare. And so today I really would like to catalyze conversations, as I thought it might be a nice way to kick off the AI Meets Ethics series about data quality in health systems, the ways that we as a society, as individuals, as researchers, as clinicians, how we shape the data that are captured and ultimately used in these technologies, some of the downstream implications for equitable AI development. Now, this might be the area that probably most are more familiar with, what that means in terms of bias, algorithmic bias. And then I'd also, again, like to center and kind of ground us all back into impacts on patients, communities, and clinicians. And I'd like to start by just kind of positioning myself and kind of stating where this came from and what shapes my perspectives, because I am really cognizant of the role of us as humans working in the field of data science and AI research is making crucial choices and making conscious choices about, you know, the ways that we run things, the tests that we run, and the targets that we select, all come from kind of who we are and how we've been shaped. And so for me, equity, or I guess recognizing equity, so that things are different for different people, started when I was young. So I come from an immigrant background. So my family came to Canada when I was 11. And I noticed very early on, you know, even when we were living in the Philippines, where I'm from, that like things are different for different people. So the first photo you see there is of Santa Claus. So my only like touch point with Santa Claus was really like somebody on TV. You know, I always knew that like Santa Claus was only for countries where it was snowing. It was only for white people. And so like they were not for us. And so I see that I show this picture here because it's kind of one of the stark examples that I saw in my life of, like, you know, we saw this Santa Claus dressed up at the mall, and I was wondering, oh, why is this a brown Santa Claus? Is not the right Santa Claus. So we get this version of Santa Claus versus, you know, the proper one that other people get. Other influences in my perspective has been growing up with a large family in a health system that's very low resource. And so I have experiences of family members, you know, not getting the care that they need because they've been turned away from the emergency room because nobody was there to foot the bill, and things like that. And then obviously working as a nurse in Vancouver in Canada, kind of seeing how things are different for different groups, and really making that distinction and understanding between equality and equity. And yeah, kind of that really shaped a lot of how I think about things and how I then kind of move forward in the work that I'm doing now. And so some of the earlier work before I moved into kind of the health technology world was really around migration, histories, understanding health worker migration in particular, and how colonial histories of the US and the Philippines for specifically kind of shaped how health systems, workforces are. And then moving into kind of more of my more recent work in the health informatics world, looking at, you know, inequities in terms of the technologies that are provided for different groups of clinicians, the effects they have for different types of people, and then more recently into looking at AI in the context of nursing technologies. And some of the key questions that I invite us all to think about today as we kick off this ethics series, really, I bring it back to power always. And these are the questions that drive my work. And I hope, you know, as those of us who work in AI in healthcare in particular, that these are remain central to our work and not forgotten. And so the core questions that I would ask are, you know, whose needs have been considered and prioritized? Who or what is driving the technology or project? So is it kind of top-down mandated? Is it a need that was voiced from patients themselves or from clinicians themselves? What is really actually driving? What's the motivation behind the project? And then what is missing, and who is missing, and who isn't represented in the work that's doing? So it's all around questions of power: who has it, who controls it? This colorful circle demonstrating or kind of illustrating all the different aspects of identities may be something that might be familiar to quite a lot of you. So this is the Wheel of Power or Privilege, adapted from Sylvia Duckworth's work. That's actually posted or used in a lot of the funding and government websites here in Canada, which I really appreciate. And this is, I found, has been a really useful tool to think about power and marginalization and identities. And how this can be interpreted or read is the closer that you are to kind of the center of the circle is the closer you are in proximity to power and therefore experience privileges. You'll see the kind of middle-ish white ring labeled marginalized is kind of how they've demarcated, you know, outside of these categories are who we tend to view in society as marginalized. And it names, you know, a few examples here of kind of what lies beyond the norm, what we consider the kind of the standard or the normal. And then the outside words labels kind of the categories of identities that we can look at. And so the social processes are listed at the edge of the circle. And you can see as you move inwards, again, the consolidation of power or the closer proximity to power, the more you move outside, the kind of further away you are. And so I find this is just a really helpful way of thinking about, you know, when we're developing technologies broadly, not just AI or kind of data science stuff, but just thinking about, you know, who are we thinking about? Who is our default that we're thinking about when we're thinking about who's going to use these technologies? And who are we excluding when we're thinking about these defaults in terms of, you know, who our kind of end users are? And so the point of AI and fairness, you know, one way that it's described a lot is ensuring, at least in the context of AI, ensuring that algorithmic processes and outcomes don't differ based on immutable characteristics of individuals. But unfortunately, we've seen really high profile examples of algorithms that just produce outcomes that are racist, classist, you know, biased in one way or another. And AI and fairness work tend to focus on computational approaches. That seems to be a dominant lens. And so, you know, this is, of course, undoubtedly important. However, one argument that I make is that this also requires additional approaches of addressing the actual data infrastructures, data production, and data quality as the root sources of bias. You know, there's only so much kind of manipulation that we can do in that kind of data intensive and the algorithmic stage and the output stage. But it is requiring a multi-pronged approach to actually get at these underlying systems that we have that keep producing these data. Also, one of the challenges is that the focus on just manipulating or I suppose the computational mitigation approaches can make it easy to misplace blame. So it's easier, for example, to identify that clinicians are biased in their documentation, but we don't really know why that might be the case. So some of the recent studies that have used natural language processing, for example, have suggested things like, you know, have found the use of greater judgment language in nurses' clinical notes when they're dealing with Black and brown patients versus white patients. And so it's easy to then from there infer that, you know, that the clinicians are biased about these patients for whatever reason. But we don't actually have a good understanding in terms of, you know, why their documentation ended up being shaped that way. And one of the studies I'll talk about that we're working on now is suggesting something, I think that, you know, for those of us in the room who are clinicians, that it's sometimes a function of data capture infrastructures, why we document a certain way and why we use particular words or why we capture things a certain way, and that it's not only implicit bias potentially, but the kind of external structures also shape how we are capturing these data, and then these are then, taken up later on. And then I just want to highlight this broadening our thinking of moving from equality to equity. And again, maybe I'm assuming a lot because we're working in the context of health here, but a lot of the work around AI and fairness still are focused on equality. So ensuring that an individual or a group based on whatever identity category are kind of, the mitigation approaches are kind of balanced in that way. While the area of equity, so as ensuring that the appropriate resources are allotted to the appropriate people, not just kind of the same across the board, has been heavily under-examined. There's a study, a review that was done by Liu et al., I think it'll come up in a later slide, that captures nicely some of the more recent developments, or summarizes nicely a lot of the work in kind of AI and trustworthiness and fairness. And one of the things they highlight is that the area of equity has been heavily understudied. And, this is something that we're still not quite sure kind of how to do. And so it's an interesting future direction because the exploration of this definition can extend or contradict existing definitions of fairness in machine learning. I know I've been in conversations with folks around, really conflating equality and equity and how to handle that, and almost taking, for example, like a colorblind approach to computational fairness, which kind of its own conversation in terms of why that's problematic. But again, I go back to this importance of having teams that have expertise in both kind of the critical ways of understanding equity, plus the technical competence to bring together to then come up with, solutions that are truly working towards equity. And so I just wanted to highlight here, to my point of kind of bringing things back to impacts on people. This is a famous study. Many of you are probably familiar with it, that came out a couple of years ago, that looked at racial bias in health algorithms. And they found that, one widely used algorithm, I believe it was by an insurance system. I don't exactly know what the system was, but it demonstrated that outcomes were different. So the algorithm was meant to assign risk scores that were then used to manage care. And so a higher risk score, I believe, meant that you kind of got triaged to care earlier on. But what they were finding, once that kind of they audited this algorithm or took apart how it worked, was that it was assigning lower risk scores for sicker Black patients as compared to less sick white patients. And part of the reason that had happened was that they were using, I think it was cost of care, as a proxy to illness severity. And because Black and brown patients tend to use Medicare, which have lower costs associated, this is kind of how it rolled out. And at the end of the day, this was kind of the effect that it had. And so I think, so my intention here with this example is just to show that there are, real implications for people with the human decision-making that we make in terms of, what are we using in these algorithms? How are we selecting our measures and proxies, et cetera? So for my own current research, main driver is starting with really the data. So that's what I'm interested in as the raw material, because this is the capacity to consider equity in digital technologies. And so part of the reason I'm so interested in data is given my background in nursing, nurses are the largest healthcare workforce in almost every healthcare system, probably in every healthcare system in the world. And as a result of that, we generate or document the most data. And so there's a huge potential, or nurses do shape what health data looked like, what health data exists for potentially future AI work. But that's not very well recognized. And so there's this kind of huge untapped well that we're not looking at in terms of, potentially really rich health data that can be used, really rich health data that are rich in social determinants of health understandings, relational care understandings, and things like that. So some of the questions that I consider core in kind of the work that I do focused on data as the raw material is questions around who do we have the most information about, and who do we know the most about in the context of health data? And given who we know the most about, what does that mean for the resulting technologies that we tend to create? And then what are the assumptions that we have upon which we build the technologies? And so I just like this visual created by the National Institute of Standards of Technology in the US that, again, I think just really nicely visualizes kind of the different layers of where biases can come in. And so the different requirements of where we can mitigate biases depending on what we're looking at. And I do think it needs to be kind of a multi-level, multi-pronged approach. And my interest, again, is around, closer to the systemic and human biases. So the under the iceberg bits of things. This is a recent study, speaking of kind of data bias. This study nicely highlights gaps where data are coming from and which data tend to be used. And so this study was a review of ML algorithms that were developed for clinical purposes in the US. And you can see I highlighted there, the majority of studies were based on data training data in California, Massachusetts, and New York. And so there's overrepresentation in some areas and no representation in other areas. And again, this is just to highlight, there are implications for, which training data we're using, where it's coming from, and then what kind of outcomes and impacts we can then gain from those. And so we have kind of the challenges in which training data are available to be used. That's then compounded with gaps in health research knowledge. And so I think this is kind of a longer known thing in the world of health research, in that we have this kind of data paucity or data poverty around kind of most groups of people besides the ones that fit in this fairly homogeneous group. So historically, looking at RCTs, looking at health research studies, this tends to be the group that we know the most about. And so in this slide, I've kind of just broken down the identity categories and what assumptions we might make about particular things based on the identity category. So we know the most about males. So we're making assumptions about, their sex and gender. We know the most about young males. So there are assumptions there, or associations with particular age and ability. They're typically healthy, white, advantaged, and Western. And so kind of our baseline or our reference person tend to be, have these kinds of categories. And so the question is, what does that then mean if we're not, actively thinking about this? And I do this all the time. You just kind of assume that everybody fits these categories when that's obviously not true. And so the resulting technologies that we tend to create tend to be things that are available only in English, use language at greater than, the average readability levels. They might be calibrated on lighter skin, based on studies that use primarily European and Caucasian populations. Assumptions about nuclear households, home ownership, socioeconomic status, and then normative assumptions of ability, and things like that. And so who is then excluded if this is our reference group and this is who we tend to target. And I think kind of bringing that to light, the compounding of, you know, the data that we have with the health research knowledge that we have, you can see how the problems kind of begin to accumulate, or the challenges anyway, begin to compound. And so I like this definition of health data poverty as again, back to the question of equity, the inability for all groups to benefit the same way from something because of insufficient data that are adequately representative. And because of this historical disproportionate focus on some group more than others, there's data poverty among all other groups. So other examples that are not specific to technologies, but will be familiar to a lot of you, you know, recognizing different symptoms of heart attacks varying by sex. This is relatively, you know, embarrassingly recently that we started to really pay attention to this. Dermatological assessments of people with darkened skin tones. I know in my nursing training, we were never trained to understand what erythema looks like on dark skin, for example. Other well-known instances, you know, drugs and intervention studies routinely excluding children, women, pregnant people, older people, people from minority ethnic groups, yet we're making, you know, claims about health and outcomes and effects as if they apply to everybody. And so my point here is that just emphasizing that these missing data matter. So thinking about how your own preferences, beliefs, and values, how we pursue health are shaped by an intersecting social location. These in turn shape how we interact with health technologies. And so if we don't have information about some groups and how, you know, these groups influence, or how these groups seek healthcare, what their health behaviors are like, how can we truly develop technologies that are going to be useful for them when we have this kind of big gap in understanding? And so other examples of impacts where data gaps have real implications for people. So we saw this with COVID-19, where we saw disproportionate impacts of the disease and related factors in some communities more than others. So this is just one study. There's quite a few out there where we saw the highlighting of the need for better collection of race-based data in Canada because we didn't really understand very well why some groups were being impacted so much more adversely versus others. As a result of that, in some places, including in British Columbia, we now have the Anti-Racism Data Act, where there are efforts to try to more meaningfully collect these data in the province. And so I present these as things that we need to think about as people who are, you know, kind of developing developing a lot AI, developing clinical decision support tools in the province. And I guess thinking prospectively about how these kinds of changes at the high level are going to potentially change what data we have access to, perhaps, you know, advocating for data that are needed for us to move towards more equitable technologies, because I think the working group was just struck in the fall. And so this is kind of very much in development in terms of kind of guiding and implementing, I believe. And so there are also gaps in what and whose data counts. So I talked about kind of gaps in training data that are available and how difficult that can be to get this beyond kind of a particular setting. We talked about gaps in the scientific literature, and then gaps in valuing data that matters. And so I would argue that there's also data poverty in relation to what types of health data are collected and tend to be used for secondary purposes in healthcare systems. some of these are a couple of the studies that we've done, and one of the things they highlight is the inadequacy of nursing relevant data capture. So anyone that's familiar with working with nursing informatics and electronic health records, this is old news, that generally electronic health records serve nursing care poorly. And I would extend that actually probably a lot of other clinical care poorly. They were initially designed for administrative reporting purposes by these large vendors, and it's only clinicians have been trying to say for a long time that, hey, actually this needs to serve clinical care as well. But they remain inadequate. Now, this study was from a little while ago on the right, 2016, where we did an international survey and found that, unfortunately, across the board, it looked like most electronic health records were insufficient for the purpose of supporting nursing needs and care. So they would, participants would identify things like, there isn't an appropriate field to document this particular type of care. And I suspect the same can be extended to other kind of healthcare fields as well. A more recent study that we did last year was a review of publications that looked at the representation of allied health and nursing data, and how social determinants of health are captured in AI applications and papers, and found that largely they aren't there, which has implications for, if we're talking about the move towards equitable AI and fair AI, and having social determinants of health, for example, is important variables to include within those. We're really missing a huge chunk of data that we could be potentially using to help improve these systems. So some of the data we're missing out on that could be leveraged for developing better AI, expertise on relational care. So a lot of progress notes, not just nursing, may touch on the delivery of relational care, of compassionate care, advocacy for patient needs, social justice advocacy and goals, patient-centered goals, for example. Current EHRs don't really have places where these can be captured. And so if these aren't captured, we can't use it for any kind of secondary purposes. So largely we're not able to link, a lot of this clinical work that we say are so important to health outcomes if we're not collecting these data in the first place. And as I mentioned already, we're then limiting the possibilities of AI, of what we can do and what kind of data we have to work with to kind of mitigate the biases that we're seeing. So in health systems, there are two key things that I see as really contributing to data poverty, or this misrepresentation or gaps in data about particular populations. So one is working in non-inclusive systems. So I mentioned already that we have the systems, the electronic health records that we tend to use, that tend to be the source of data that we use for AI, are legacy systems that have been built for administrative reporting purposes. And so they don't serve clinical needs very well and don't capture clinical needs very well, although I know there are good intentions and developments towards improving those. Within our non-inclusive systems more broadly as well, like our healthcare systems, we value some data and not others. So we tend to value and therefore collect data on particular groups or concerns. So whatever, the Ministry of Health has set as a priority, those are the data that we know are going to be collected for sure, because it is what's prioritized and what we see as valued. And so there's a valuing, there's a hierarchy making of what data are important and what are not. A challenge in healthcare systems, as you all I'm sure will know, is moving beyond the status quo, so changing how we do things. So realistically, capturing more representative data is going to require changes to EHR design, changes to our conventions of documentation and capturing work, which is huge in terms of, shifting cultures and ways of doing things. So that's going to be a big challenge. And then also our emergent understanding of what types of data are important to which groups of people. And so it is encouraging to see things like patient-reported outcome measures and patient-reported experience measures as things that are being emphasized as important. And we have, intentions of ensuring that patient stated goals are captured in the notes, and that's how we deliver care. In terms of operationalizing how to capture that, it's going to be, quite complex and part of the challenge. And then there's, of course, implicit bias at the individual clinician level. So this can make their way into clinical documentation. So there is some evidence for this. And there's also evidence that suggests non-random missing data, or the collection of non-random missing data among some population groups. And so there's, we see sometimes in clinical documentation that sometimes maybe the language that's being used in narrative documentation or communication, where we're labeling patients or making a judgment about a behavior or whatnot. If that makes its way into clinical documentation, what does that then mean for data reuse? And then there's evidence of data entry in electronic health records as reflecting the cognitive bias of clinicians as well. And so what to make of this? I guess my key point is, back to that kind of multi-pronged approach of moving towards equitable AI. And at least, my work is really highlighting or trying to focus on the importance of addressing data creation and data quality alongside developing computational approaches. So ensuring that we're working together kind of in our areas of expertise and then coming together to come up with creative and innovative ways for mitigating imperfect, incomplete, and non-representative data. And so it's going to take both, the structure changes, culture changes, and, how conventions are on documentation, and that for things to kind of really come together or move towards better quality and more representative data. And then I'd like to introduce the question of then complex care concept. So we say a lot of things in our health system about what we want and what we prioritize and value. So these are a lot of kind of words that you see a lot of the time being thrown around. We want our healthcare system to be patient-centered. We want our system to be equitable. We want care to be trauma-informed and intersectional. That's all well and good. My question is, how does that then translate to capturing those care concepts in the electronic health record? Those of you who have a clinical background will know, unless something's documented, it basically didn't really happen. And so are our systems designed to capture these things? We say these things are important, but is there a space for us to actually, have it exist in the records and therefore potentially be used in developing AI or as targets? Do we know how we get to a patient-centered outcome and what that involves? How does this all translate? And the two reports here, in particular, I want to highlight, a lot of the recommendations that are made for decolonizing healthcare, addressing Indigenous-specific racism in healthcare, involves a lot of concepts of care that are very complex and that are not easily amenable to an EHR design. How are we going to handle that? And if we truly value it, it needs to show up somewhere. But what does that look like? And how do we start working towards that?
Thank you so much for that enlightening talk. And we have a great participation in the audience in terms of people who showed up, and I'd like to open it up for any questions to Charlene. Well, I have a comment and a question. So I'm also working with the electronic health record. Before the pandemic, Cerner was implemented at the hospital that I work at St. Paul's. And I would just like to echo some of the comments that you make in terms of rigidity of formats. And even at the beginning, in order to do the data creation, there were no spaces for things that we thought were typically important. And the pre-populated notes that then come together aren't even in a format that we teach our students in terms of how to present. So you would think that form would follow function, but what's happening is that for learners, sometimes they're presenting like the format, how it is, which is not logical in any way. So it is even a challenge just at this, even as a learning environment with some of these electronic health records and then the data capture. So just wanted to know if you had any experience with that as well.
Yeah, absolutely. And that's what we heard. You know, there's kind of the things that you're taught in terms of, I'll speak specifically to social determinants. So the things you're taught in school in terms of what to assess and what's important. And then, yes, you're faced with this screen of what you actually need to put in. On top of that are the policies around documentation of what you do and don't document. And we heard a lot about navigating those, right? So, you know, part of the challenge that we have as well, I don't know if this is true in other fields, but in nursing, oftentimes it's documentation by exception. So you only see things that are not normal. And so kind of we don't know what we have an assumption of what normal is. It's kind of taken for granted, but we don't actually know for sure what that is. So part of this work that we're doing, we're finding, like as we're kind of requesting data and working with the health authorities, is also having those conversations around, you know, like, hey, is it time to rethink how we document and how does that align with EHR design? And it's really, it is a really complex, wicked problem because you kind of have to get at it from all angles. So one of the things we're trying to do is involve, you know, people who have some control around EHR design, people who have some say or control around documentation policies, and kind of just starting those conversations at this point, I think. But you're right, like it's easy to kind of, it's almost like teaching to a test, right?
Yes.
Yeah.
Yes. It's very challenging. And can you comment about, with all of the text data that with the different disciplines, what do you see the role of how could one use natural language processing to extract themes? And I just wanted to hear your approach of that analytical computational method in terms of thinking about how might you design a study for a research question using electronic health data and the pitfalls or the potential strengths. Thank you.
Yeah, thank you. Yeah, so for our particular study, we're using a program that was made, you know, by a colleague called Nimble Miner that's been tested with clinicians as easy to use. And so I'm working with folks who know a lot more about the computational aspects of NLP. And I think this is where we need to kind of come together. And so part of the challenge still, so that's, Nimble Miner. I have a bit of a stuffy nose. So that's a program that just runs in R, and that, you know, you can kind of train it on your data, and it picks out the clinical concepts and builds kind of your synonym of your dictionary of terms from that. So there's programs that exist that are kind of standalone. I don't know if folks have heard of NIME. That's another one that's just like a visual interface where you can do some NLP things. I think you do really need the expertise of somebody, especially like with knowledge of linguistics, because like we have some basic understanding of, you know, like how NLP works, whatever predicts the next word, you have kind of the general gist of how it works. But in terms of how language works, I feel like you really need like a linguist who knows how language works, a clinician who knows that subclinical language and what that means to really have an extraction plan that is really catered to that particular type of progress note, rather than, I mean, you can get some insights from a generic approach, I suppose, but I wonder about missing some of the specialist language. Like one of the things that we heard from nurses was, yeah, kind of the sub-language that exists even at a unit level, right? Where they say, oh, this word actually in our unit it means this, but we can't write that in the documentation, so we write this word instead. Yeah, that's kind of how I see it coming together.
Thank you. There's a question from Diane Gutti. Thank you, and great references. Do you have any thoughts on how to jointly develop guardrails for a common approach across health, the design and use of AI?
I mean, yeah, like you say, this is a hot topic and my mind changes kind of every other day about this. And I think, you know, there's been efforts. I was just reading this morning, this kind of New York Times article about how the EU has put out kind of AI, there's like I forget what it's called, but like guidelines around developing safe AI. The UK have put some out, other countries are putting out a bunch of things, and the EU had very, I think, smugly said they were sort of future-proofed until ChatGPT came along. But I think, I guess my thought is always kind of to bring it back, like to not forget about the people at the pointy end of the things, and, you know, touching base with patients about like, what are the actual impacts on them, and like, what would that actually look like from them? And then maybe work backwards in terms of, you know, how do we get to a point where that kind of safety is ensured? I think we all make assumptions about, you know, what safe AI use means, and it's not, you know, it means not harming people, but like not harming people is different for different groups as well. And so
Suffer said, great talk. Even if we're unable to fully remove biases in AI models, could we at least improve our understanding of biases that are present in all models that we create?
Yes, absolutely. And I think this is part of the intention or the hope with the AI Meet Ethics series, is to get us to think about these questions. I mean, I keep repeating myself, but it's really like having that team who have the views from all of these different places. Like the one thing that we found so helpful is like our team has, you know, clinicians and technicians and health authority people who can like just contextualize how the data come to be where they are and how they exist the way they do. I think that goes a long way in then helping us think about, yeah, like what is an appropriate approach for this particular type of data set, knowing that whatever in community nurses document in this certain way, and this is what their EHR looks like, and this is what the data look like at the end of the day. Absolutely. And I think not missing the human part of it, like we all make choices as we're developing this work, and not to miss that, like those choices matter in terms of the outcomes that we have, and that like we all have biases and we're all learning. And I think that's the thing. A reception that I've given this talk a couple of times, and one of some of the reception is always like people are afraid to do the wrong thing, which is fair, right? Especially when we're talking about social determinants and equity. People are like, what if I'm not asking the right, I don't know, identity categories or whatever it is. But I think approaching the work with humility and saying, you know, like, yes, we're not going to get everything right the first go at it, but, you know, having some guardrails in place so it's not, you know, harming people. But I think just being open that like we're learning as we're going, and it's just like the pace right now is not helping, because it's really not, because we're all kind of panicked. But I think, yeah, we need to kind of, you know, again, I think by bringing it back to patients and the people, it will force us hopefully to slow down.
I have a question on the issues around AI ethics and commercialization. and the whole private sector in terms of health, and just wanting to get your perspective on that. It's a broad question, but just
yeah.
But I think a lot of people are thinking about this space and that commercialization opportunity, but also like the light and the shadow of it too, when you want to scale something that might be good, right?
Yeah. And I do have conflicting feelings about this. Like, I know, I think it was last year, there were a couple of news stories about, I think it was Epic that put out a couple of clinical decision support models that were like totally black box, and like they just refused because it was proprietary. That's really, to me, that's really problematic, because that part of, what clinicians have to do is basically like, you have to trust it enough to say that I'm kind of leaning my clinical decision on this. So I have to know how it works, because I need to be able to explain it to patients and families, right? How it came about this. So, so that's, definitely a negative. Like, I see kind of researchers contributing to Equitable, but then like I'm torn, because it's like, I don't know, there's this, then technology is just, these developments then go to the vendors, right? We do all this work to make them more equitable, and then ultimately we have to integrate it into some kind of system to make it work. I don't know a good answer to that. I think, I guess what we can contribute is like approaches, and hope that the vendors take it up. But again, yeah, it's this kind of interplay of like private, public, for profit, for greater good thing. Yeah, sorry, I don't have a great answer to that.
Well, I think it's just it's a very complicated topic, and our regulatory framework hasn't caught up to any of this either, right? Like,
exactly.
Like, we have a regulatory framework that I think worked better 20 years ago than the world that we're currently in. And so I think that's part of our challenge going forward with these, exciting advances, but we're catching up to everything, right? In terms of
yeah, absolutely. Like on a practical level, for I think a lot of folks here who are like, trying to develop AI models, like privacy laws, like you said, like all around, it hasn't kept up. Like what the study that are, and not to kind of give our healthcare partners a hard time, but like they're working within the structures that they have. But like, we requested our data a year ago and we're still waiting. So things are not conducive to development. And I think these like conversations and developments need to happen if we do want, because we're almost like, either the proprietary stuff is going to get developed, and they have, like in comparison, unlimited resources, unlimited access, and we're having to work within these systems that, as you said, were designed for 20 years ago. How can we really kind of, do that in a meaningful way? But yeah, there's a lot of catching up that needs to happen.
And just to your point, I completely agree with you. I'm also concerned that the proprietary stuff, that work may not be as concerned about the biases that you've highlighted, and that makes so many people vulnerable. And yes, the recording will be shared, and we'll talk to Dr. Ronquillo about the slides as well, but they'll be on the recording. I want to thank you so much for an incredibly interesting talk and for sharing your expertise. So and thank you for everyone coming today. Really excited for you to share our inaugural seminar series in AI and ethics. And we look forward to you joining next time.
Thanks, everyone. Take care.
Bye-bye.